Hello and welcome. My name is Dr. Atul Malhotra. This session is entitled Roundtable Safety and Efficacy Data on New Therapies for Excessive Daytime Sleepiness in Obstructive Sleep Apnea. I'm the Research Chief for Pulmonary Critical Care, Sleep Medicine, and Physiology at the University of California, San Diego. I'm a professor of medicine here doing research and patient care related to sleep apnea and other conditions. I'd like to introduce my friend, Dr. Neomi Shah.
Thank you, Atul. My name is Neomi Shah. As Atul mentioned, I'm in New York City at the Icahn School of Medicine. I'm a professor of medicine and also the Assistant Vice Chair of Faculty Affairs for the Department of Medicine, and it's a pleasure to be here.
Great, thank you. I'd like to learn from your experience in sleep apnea. So if you see a patient on CPAP who has residual sleepiness, what's your thought process?
Yeah, usually the first thought is, are they using their CPAP enough? And once we've sort of established that and they are using it to the degree that I'm satisfied, which is usually at least 4 hours, but ideally for the entire sleep duration, if their residual AHI is less than 5, and I've established that they're getting enough sleep, I'm looking to see if there are any other potential alternatives that I can offer, either medications or other behavioral interventions to help improve that.
Do you find the downloads quite helpful in that context of assessing those patients?
Absolutely. They're critical.
Okay. And do you find other sleep disorders come up? Because sometimes people talk about narcolepsy or other conditions that may be coming into play, or do you find that residual sleepiness is common in sleep apnea with or without other conditions coming into play?
Yeah, I think insufficient sleep is really the big one that comes up. A lot of times they're just not sleeping enough. In terms of sleep disorders, insomnia is a big one, at least in our population here in New York City. So those two are really the main ones that come up.
Yeah. And then if you are reaching for pharmacology, what's your thought process there?
Yeah, so I'm usually reaching for the ones that I'm familiar with, the ones that I was trained with. And so they're typically modafinil or modafinil. I am finding that I'm using solriamfetol more, primarily in my patient population that are on oral contraceptives, as that's a nice one. You don't have to worry about checking all of the different devices or potential oral OCPs. So that's one of the main features that I reach for solriamfetol, but I'm still very comfortable with using modafinil or modafinil just because of the track record.
Yeah, I have that issue as well. Modafinil and armodafinil interfere with birth control pills, and they're teratogenic. So I'm kind of call it double whammy. I'm quite careful about using those drugs in premenopausal women.
Yeah, and up until we had solriamfetol, it was really disappointing to have these conversations and try to figure out which IUD is potentially safe or not safe. OCPs are easier, but the IUDs I found, I had long conversations with the pharmacist to figure out whether it actually does make a difference or not.
Yeah, and that's not really in the skill set of many sleep physicians. It's something I was very familiar with.
Or intensivists, for that matter.
Yeah, fair enough. And do you have insurance issues getting coverage for the newer medications?
Not usually. I think as long as we've established that they've tried these drugs and they haven't really responded, or there's clear-cut contraindications. We haven't had too many, but it's not like I have hundreds of patients on these new meds. This is obviously still a new area. So most of my colleagues and I are having, very little difficulty getting this approved compared to, for example, Xyrem or, sodium oxybate. That's a much sort of a bigger problem in terms of getting approval, getting the paperwork done.
Yeah, agreed. And I don't know if it's referral bias or what, but I see a lot of patients who don't do well with modafinil who then come for seeking alternative therapies. And maybe it's just the ones who are happy with modafinil don't necessarily come to see me. But do you find that as well, that there's a patient switching from one drug to another because of incomplete efficacy?
Absolutely. We see that all the time. And it's very hard because you just kept going back and forth between modafinil or modafinil, and then you went back to sort of the stimulants, which I was never a big fan of.
Yeah, agreed. How about with side effects? Have you had much experience with solriamfetol side effects? I've seen some nausea and some headache, but not, in general, they're pretty well tolerated.
Absolutely. Yeah. I haven't seen anything major. I mean, anxiety, headaches, sort of the two main ones that I've seen, but nothing beyond nothing where they would have to discontinue the medicines. Yeah.
And full disclosure, as you know, I was involved in some of the studies, and, the efficacy and safety did look pretty good for these new medications. But as you say, clinical experience is still early days.
Yeah. And there was a really good meta-analysis in the Annals of Internal Medicine that also basically showed the same thing you just said.
Great. Thank you. Thanks for everybody for joining us today. It's been a pleasure. And thank you, Dr. Shah, for your insights.